right. So today we're talking to Nicole Lamberson. Nicole is a physician's assistant who has been through the process of benzodiazepine and other psychiatric drug withdrawal and has become something of an expert in the field, having spent years helping people manage coming off their own drugs, mostly benzodiazepines, but also other psychiatric drugs. She has been one of the leading lights in the Benzodiazepine Information Coalition and is now their medical director. And she has done a huge amount of advocacy work, but more particularly, she's helped maybe hundreds, if not thousands of people come off psychiatric drugs.
Yeah, I'd say that's fair.
She suffers from an excess of humility, but she's someone that I often turn to for advice when I'm stuck. And I guess what we're trying to do here is a series of expert interviews. And you might think you'd go to a professor of psychiatry at Harvard or Stanford, but interviewing them about this topic would be mostly dead air. So I have gone to the real experts. We're talking to Adele Framer, Angie Peacock, Nicole, to people who have seen thousands of people come off these drugs. Is there anything else you wanted to add to your biography before we shoot through some questions to give some context?
No, I don't think so. Other than I do, coaching myself, and I also wrote or co-authored the Withdrawal Project with Laura Delano. Yeah,
it's true. That's a great resource where one of the things I started reading when I was coming off my drugs. So she'd just been in the New York Times, in a mixed write-up. All right. I guess the other thing to say is I know that a lot of what you're dealing with are people coming off benzodiazepines and a little bit on antidepressants. I guess from what I've seen, there's a great amount of similarities between the issues people have. And so when I'm asking these questions, ideally answer it about antidepressants, but if it's about benzodiazepines, I think it's almost interchangeable because the issues are the same.
Yeah, agree. And I have plenty of experience with the antidepressants too. Lots of people are on more than one, and I just treat them the same, really. Like you said, they're very similar.
Yep, exactly. I take exactly the same approach. So my first question is, in the textbooks, it says withdrawal effects should come on in sort of 3 to 5 half-lives after a drug is stopped, which generally means a few days. Have you seen delayed onset withdrawal effects where the onset of symptoms is a few weeks or longer after stopping?
100% yes. In my own experience, my withdrawal was delayed by 4 months. I had some withdrawal effects immediately, but the most severe withdrawal did not start for 4 months. And my father's an anesthesiologist, and he kept saying, this doesn't make any sense. Why is it getting worse? But I've encountered countless other people coming off too. The longest I've seen is a girl I interviewed who said a year from effexors when she got most severe. Now, I don't know if, maybe it was she had a setback at that time or something, but that was her story, that she took a year. But most people, I would say, it's within, a month to 6 months I've seen for delayed withdrawal, both from antidepressants and benzodiazepines.
Yeah. I've seen the same. I've seen weeks and months. And a bit like your father, when I first saw it in people, I thought, that doesn't make any sense. How can the drug take that long to come out of the system? I guess since then because everyone asks, well, what's the mechanism? How could that be biologically plausible? And I guess there must be downstream effects that take time to accumulate. There must be genetic changes, changes to receptors that take time to accumulate. I don't know what it is, but I've now seen it so many times. And I guess people say, well, isn't it relapse at that point? Isn't that something like an underlying condition? But I've seen brain zaps, dizziness, headache, classic withdrawal symptoms at that time that are quite distinct from what would be a relapse.
Yeah. And I mean, in my case, how could it have been a relapse? Like, I took meds for stress at work, and the stuff I was experiencing was, suicidally bad, extreme drug withdrawal. So there was no way, that it was relapse. Yeah.
Yes, I often think that as well. It's hard to have a relapse of divorce or work stress when you're already been through that.
Yeah. Or people we see who took it for, like post-surgery from something that caused like back spasm or, muscle pain. And then they're having all of these psychiatric manifestations that they never had prior.
Yes, I think
Yeah.
exactly. Someone's prescribed it for a non-mental health reason. It makes it even more obvious that these symptoms are withdrawal. I guess it's confusing to clinicians who are used to seeing psychiatric symptoms as mental illnesses.
Yeah. And the patients will tell you. I mean, I have lots of clinicians that I train who will say, well, how do you know? How do you know it's not relapse? And I'm like, they're usually shouting at you, what's happening to me? I've never felt this way before. Like, this is so extreme and horrible, way worse than anything I ever felt before the medication.
Yep,
So,
yep.
yeah.
So I can't remember who the famous medical physician is, but his quote was, "The patient is trying to tell you the diagnosis," and that's really overt when it comes to withdrawal.
Yeah, exactly.
The next question I wanted to ask is, we're talking about sort of severe presentations coming off the drugs, which won't happen to everybody, but what does akathisia from coming off these drugs look like? What sort of state have you seen people in?
So I think akathisia exists on a spectrum. There's severe akathisia and more mild akathisia, but on the more severe end, people are usually inconsolable, hysterical. They tell you that they can't stop moving. Sometimes they pace until their feet bleed. They literally cannot sit still, and they'll tell you, I'm trying to escape myself, even though the act of moving doesn't resolve the symptom, but I can't stop moving in an attempt to, I guess, try to make it go. They're usually quite panicked. Most of them are suicidal. They complain of agitation, like rapid firing thoughts. And then sort of the lesser end of that is sometimes people say, like, I have inner akathisia where I'm not moving, but I'm almost like on the cusp of it. Like I feel like I might want to, but I don't have to move. It's just like a milder kind of version of that.
Yeah. Exactly. I've seen that, and I've had the pleasure of experiencing it firsthand, at least moderate akathisia, which was one of the worst things I've ever been through in my life. That sort of terror, agitation. I wasn't quite pacing all day, but I was going for long runs to burn off energy that was sort of tormenting me.
Yes, I also experienced it firsthand, and it felt like, and I've talked to other akathisia survivors as well, who said it, like, to me, it felt like it was coming from my spinal cord. I don't know if you had that yourself, but it was like torture tickling of my spinal cord is the only way I could describe it. Yeah.
I haven't heard that description before, but okay, that makes sense.
Yeah. Mm-hmm.
And can I ask, what sort of misdiagnoses are people with withdrawal akathisia given when they encounter doctors in general?
Oh, yeah. So, like we already discussed, this is just, probably a relapse or a recurrence of the original condition. Maybe it's some new onset mental illness like generalized anxiety disorder, major depression, bipolar, panic disorder. I think some people get all kinds of expensive testing and go down these rabbit holes for like, oh, maybe you have MS because they have all these neurological manifestations as well. So I think it's, the gamut of neurological conditions and psychiatric conditions, really.
Yeah, I've seen exactly the same. We've done a paper on it where clinicians who aren't aware of this, seeing a very agitated person and they go mania or agitated depression. Sometimes I also see when people aren't quite as severe, they're not at the emergency department, but they are become very needy, I guess is maybe not the politically correct word, where they need reassurance, they're reaching out all the time, they're emailing, they're phone calling, and people who aren't, I've seen lots of these cases sort of start to think this looks like a personality problem or psychosomatic, this is a very neurotic person worrying. Have you seen that
Yes.
kind of response?
Oh, yes, completely. Agoraphobia too sometimes manifests in this, where people say, oh, you just need exposure therapy. This is an anxiety disorder called agoraphobia, because people become so fearful, they can't even leave their own homes. So
Yes. And I've seen also, what's the word they use, monophobia, where people are afraid to be by themselves because
yes.
they're so agitated, they're so afraid they might hurt themselves, they feel so scared, they feel so terrorized.
Yeah. Also rage. For me, I had severe rage as a symptom, just uncontrollable anger. I mean, it completely changed my personality into this aggressive, moody, crying. I threw things, I screamed, and that is not in my personality at all.
I know Nicole, she's a very pleasant person. That does not
Yeah.
the person that I know. I think if someone had encountered me at that point, they would have thought I mean, maybe they would have thought that anyway, that I'm a basket case, but at that point, a serious basket case, because I was trying to survive, basically. I was trying to barely hold on. I was doing whatever I could to
Yes.
survive. So because we see these sort of patients in outro, and they're often difficult to deal with because they're in so much pain. It's very, it's unpleasant, even to interact with them because they're so all over the place.
Yeah. And they'll ask you the same question over and over and over again, every time you meet with them. It's no good to say once, like, it's going to go away. It's every day, all the time, again and again and again. How long is it going to last? Because they are so tortured in their own skin that all they can think about is when it's going to stop. When I talk about my own experience, I say, like, when people were like, well, just relax, people would say to me, or just, it's like, that's like telling someone, who's burning alive, like, don't think about the heat. It was that bad. And when you say survive, that is truly the word for my own experience and some of the other more severe patients that I've encountered. They are barely surviving this. So, yeah.
Yeah. I mean, it does present a big dilemma. Even if you do recognize it, what do you do to help somebody? Because you're right, everyone sort of goes through, well, could you try mindfulness? Could you try exercise? Could you try taking a cold bath? And people get a bit angry about that because they're saying, I've heard people say exactly that. This feels like my nervous system is on fire and you want me to go and, light a lavender candle. It's sort of like bringing a fork to a knife fight kind of thing.
Yeah, and it also just feels a little bit like, you didn't think I already thought of that? Like, if I could go for a walk and feel better, I would have done that. Like, I'm not stupid, I can't escape this. There's no escaping it.
Yeah. I mean, I'm not sure what advice to give. I sort of give people, I say just crawl through it if you have to. Whatever you do that takes away 5% of the pain, do that. Do it 10 times a day. If pacing helps, if screaming into a pillow helps, scream into a pillow. I sort of say do whatever it takes to get through it.
Yes.
More wise.
For me, distraction is part of the reason why I survived. I mean, I just literally had to have my brain doing something all the time so that I wasn't thinking about how horrible I felt. I took tons of baths and showers, not because they did anything for me, but just because I was doing something. I did not know what to do with myself. So I was stringing hours of the day together, literally, until I could collapse again and then get up and do it again the next day, essentially.
Yeah. It's awful.
Yeah.
I mean, the other thing that I guess where this comes in is, people often say, well, why don't I try to come off my drug quickly? That'll be easier. And if it doesn't work, then I'll, go slower. I'll take your advice. And my response to that is, you're taking risks. And one of the risks you're taking is, you could become very suicidal or develop akathisia.
Yeah.
And I don't know, I guess it's I don't know how common it is. That's one of the things, there's not enough research. So is it 1% of people? Maybe then it is worth taking the risk. Is it 20% of people? Then I don't think it is worth taking the risk. So I'm always trying to say to people, the risk of things going badly is so great compared to the risk, compared to it's a bit irritating to spend an extra 6 months or 12 months coming off. But when you balance things up, I mean, you could, to get down from the top of a building to the bottom, you could try jumping. It's quicker. You'll save yourself all those stairs. Obviously, the risks outweigh the risks of taking longer. I sort of put it to patients. Not everyone accepts that. Do you sort of have a similar discussion with people?
Yeah, I mean, most people you encounter once they've decided they want to come off their meds are in a rush. It's like, oh, well, let's get this over with, myself included. That's how I got myself in the mess that I did by coming off too quickly. And if we can't predict what's going to happen from one person to the next, to me, the risk of getting as sick as I did, or as you did, or some of these other people did is so great that it might cost you your life. And so it just seems like the scales tip in the direction of let's be preventative for everybody, or at least give them the warning. The problem is it's really hard unless you've experienced this yourself or seen it a bunch to put into words to somebody what they could potentially feel inside of themselves if it goes wrong. How do you verbalize how severe and terrible it can be? So I just try to let people know, sometimes if you open that door, we can't put it back in. If you ignite the flame in your nervous system, Yeah, sometimes we can updose or reinstate and fix it, but for a percentage of people, we try that and it fails, and then you're stuck
Yeah.
in the withdrawal syndrome that you've started, and we can't make it better. And so to me, it's a huge risk, even if it is a smaller percentage of the population. It would be nice to know that number, but until somebody does that study.
Exactly. So
Yeah.
I'm in lockstep with everything you just said. That the severity of the risk is so great, even if the the odds of the risk is unknown. That why do it? Why? I guess lots of people who would jump out of the third story building to get to the floor, probably a lot of them would roll and be okay. But we know that there's enough people that would have serious trouble with breaking their legs that we recommend not to do it. And you're right,
Yeah.
it's very hard to articulate to people, because I sort of realize that in lectures I give, I put all these symptoms up on a list. It says agitation, it says terror, it says pacing. People think, oh, that sounds unpleasant. But they don't understand that, people are barely trying to not kill themselves because they're in so much pain. Sometimes when I'm trying to frighten a patient straight, in other words, to try to convince them not to go so quickly, I will send them to something like Akathisia Alliance to show people, sort of talking to the camera about how distressed they are. I'm still not sure if it really hits home, because some people must think, oh, these sound like crazy people. What's it got to do with me?
Yeah, I mean, I'll admit, when I first got here, I looked at Benzo Buddies and saw the 5 to 6 to 7 to 10-year timelines and thought, well, this is a population of people who are on psych meds, it can't be. There's a level of denial, until it happens to you. And then you're like, it's real. It's definitely real. Yeah.
So we've had near identical lives. I did exactly the same thing. I went on surviving antidepressants. I saw people took months and years to come off, and I thought, that's not going to be me. These are who are these people? And I came off in 4 months, and I was there, holding on for dear life, for running until my feet bled, barely trying to get through the day. So I was also pretty stupid and had to learn through first-hand experience. But especially because I sort of thought, well, everyone's on these drugs. How can they be this bad to come off? Surely I would have known about this. So there's all sorts of kind of cognitive.
Yeah. Why would doctors prescribe something if it did that? That just doesn't make any sense. Yeah.
Yeah, exactly. So actually, I want to, I'll ask one more question. I'm going to come back to reinstatement, which you mentioned, but I want to kind of drill into that a bit.
Okay.
I think there's sort of 3 major serious risks of coming off the drugs. One is akathisia, we've just talked about. Number 2 is suicidality, which probably is a bit related to akathisia. People who have never been suicidal before can become suicidal on coming off. But the third issue I spent a bit of time talking about is protracted withdrawal, or persistent withdrawal, all these different terms. So, these are people that have come off too quickly and they've got symptoms that last for months, sometimes years afterwards. What have you seen people go through in protracted withdrawal? What sort of symptoms? How much effect on their life? What have you seen?
Yeah. So it's typically the same symptoms as we discussed earlier, only over time they tend to get less severe in people, but they persist. Sometimes they come and go. That's where the wave and window terms were developed. Patients started calling them that because they're like, I thought this was gone. I was having this window, this break, and then all of a sudden it came rushing back in like this tsunami wave. And now I've got this symptom again,
Maybe just explain that, because I don't know if everyone listening will be aware of it, but so windows and waves is this idea that waves is when your symptoms are increased. It can be for days or weeks, or sometimes longer. And a window is when your symptoms are relatively lessened. People get a break from their symptoms. And it's so this idea that people think that healing, people have all these symptoms and that they think that it'll go away over time like this, but it ends up going like this, up and down. And it's particularly confusing because the doctor says, well, this looks really flaky because I saw you last week, you were fine. Now you're saying you're very unwell. This sounds like psychosomatic. This sounds like, mental health. This sounds like, this is not what I think of as an organic pathology. And that's, it's so commonly talked about this up and down. I can see why doctors are thrown by it. But quite a lot of conditions have that kind of up and down. People have attacks of multiple sclerosis, or their arthritic pain goes up and down. Is it to do with environmental factors? Is it some sort of the healing process is kind of non-linear? It's probably a combination of things.
Yeah. Who knows? But we definitely see it, I think I've seen, years and years. I myself, let's see, I initially cold turkeyed in October of 2010. I reinstated 4 months later when my delayed syndrome got severe. I tapered for 18 months and came off after, 2010. So you do the math, it's 2025 and I still have symptoms today. And I know other people that I met in that time frame that do as well. Granted, they're a much smaller percentage than the people that I also met that are fully recovered and back living their lives. I tell people when they ask me timelines, first of all, I can't predict. Obviously, that's the number one thing. We'd be, billionaires if we could answer that question because it's the number one thing that everybody wants to know. But from what I think, anecdotally, it looks like this bell curve kind of. And on this side are the people who are, I would consider lucky, maybe they heal in a month from withdrawal and then it goes up, and I think the average is somewhere between like 2 and 5 years is where I see like the most people recover. And then there's the unfortunate bunch that are on the other side of the bell, that go on for 5+. And so the longest I've seen is like 15. But of course, where I am now is massively improved from where I was in the beginning, but it still drastically affects my life. I mean, I don't fly on airplanes yet. I've only been able to drive, 2 hours distance in the last couple of years. And this happened to me in 2010. So it can go on and on for years in some people.
And what are the most common symptoms? I mean, there's a very long list, but what are the sort of things people have that persist?
Still anxiety and panic, lots of burning, kind of nerve pain people report. Insomnia tends to linger, muscle spasms, dizziness. I think those are kind of like the top ones that I hear.
Cognitive problems. I see a lot of concentration.
Oh, yeah.
Memory issues.
Memory loss, cognition. Yes.
Yeah. Right. I think people find it very surprising to hear these things can last so long. And I know that there's also been, in the benzo world at least, this idea that actually calling this withdrawal is a little bit misleading. One, because a lot of doctors have in their minds withdrawal is a few weeks at most, and years later, what's going on. Number two, which again we'll get back to, is that reinstatement of the drug doesn't generally fix people who are years off with these sort of symptoms, kind of implying there's a different process going on than withdrawal, because withdrawal implies to people, well, you've withdrawn a drug, so you've got it, you're missing it, that's why you get symptoms, go back on the drug, symptoms should go away. And that's not the case for most of these people, which we'll talk about in a bit more detail. And so I know benzodiazepine people have started to call this benzodiazepine-induced neural dysfunction, with the idea that something that either being on the drugs or maybe particularly coming off them quickly has basically caused some kind of injury, irritation, or damage to the nervous system, which makes a lot of sense to me. That if someone's having shooting pains, burning, cognitive problems, 10 years off a drug that's not being improved by going back on the drug, that something has happened where the toothpaste can't be put back in the tube in some way.
Yeah. And I've heard it called neurotoxicity too. Like, is it neurotoxicity from the drug itself, or is it from, something the drug caused, like some, hyper excitation of the nervous system that just did something damaging to the, the nervous system when you came off too quickly? I don't think anybody can answer that. But if I tell anyone, especially someone medical, that I'm in withdrawal and they say, when did you stop? 2012. They look at me like I have 3 heads, So It's easier to say, I acquired, and makes more sense. I acquired some kind of neurological insult from coming off, too rapidly from psychiatric medications that I was taking, and it's left me with the following symptoms.
I think that makes a lot of sense to me. I mean, I don't know where it came from, but I think people talk about withdrawal injury or some kind of nervous system injury. I think that makes a lot of sense when you see these sort of symptoms. I mean, you mentioned, for example, MS along the way. I think that this looks in lots of ways similar, although often more severe than a condition like MS. In other words, the nervous system is malfunctioning in some way. Otherwise, why are people getting shooting pains, neuropathies, muscle spasms, trouble thinking straight, panic attacks that they never had before? So and I want to always know the mechanism. People around me are, very keen on what's the biology of it all. You mentioned the word neurotoxicity. I wonder if, changing the balance of chemicals in the brain very quickly causes some kind of neurotoxic storm, something that we don't understand very well. What are these drugs doing in the long term to the brain? We're really quite clueless. We've got studies in animals, in short-term studies, but we don't really know what's going on.
Yeah. All I know is what it felt like. And when you say that description that you just said, yes, I would say it inside of me felt like someone poured water on my motherboard and it just went and just fried. I mean, that's how I felt neurologically.
Yeah. That's a disturbing image about your brain, but I feel the same. I feel the same way, and I think that makes a lot of sense. I think a little bit about long COVID or something where an acute viral infection causes long-term, presumably some kind of damage or injury in ways we don't quite understand, but we sort of all recognize because it's so widespread. And also I think because a lot of doctors, have it. So it's sort of a bit more respectable people talking about it.
Yeah. And there's not the element of taboo because it's a psychiatric drug. Like we know chemotherapeutic agents cause lasting nerve pain in people and nobody questions that. So.
Right. Yes. So this is a little bit about stigma and about not quite believing psychiatric patients because they've got psych drugs next to their name. Yeah, that's totally true. Which leads to the next question, which is what sort of misdiagnoses are people in protracted withdrawal often given?
I think we answered that one already.
It's the same sort of thing as people who with akathisia. People are, or it's slightly less kind of acute. People are told that they've got mental health problems, neurological problems. They're risk for MS. They're told they've got personality disorders. They're told they've got functional neurological disorder is a bit of a common one in the UK, which is basically saying psychosomatic. This is something in their head.
Yeah, chronic fatigue syndrome, is one over here that they use quite a bit. POTS, I've heard people diagnosed with. So.
Yeah. Yes. And then there's I sort of seen a bit of a thing where POTS and chronic fatigue syndrome and histamine intolerance. I see people say, well, that's the sort of thing that these neurotic patients get anyway. That's sort of what's going on. And now there's drugs involved. Well, that's just all part of, they're a difficult person. Whereas I think in all of these things, what's missing from the diagnostic lens is, how much iatrogenic harm these drugs are doing and could explain all of those different diagnoses.
Yeah, exactly.
Yeah. So I wanted to talk a little bit about reinstatement. So there's kind of an idea when I'm talking to clinicians who are interested in this topic and engaged with it. They understand slow tapering makes sense. But they also have the sense, well, not everyone needs slow tapering. So, why don't we go more quickly? For some people, if things go wrong, we'll reinstate and we'll go a little bit more slowly. I don't want to say that's completely the wrong approach. Because I don't think everyone should take 5 years to come off their drugs. I don't want to shoot too far. I've seen that reinstatement is not always as the textbooks says it is, where it always solves people's problems. What have you seen with reinstatement? What sort of things can happen?
And when you use the term reinstatement, you mean someone's completely off and they're going back on versus like updosing mid-taper?
Yeah, let's start. Let's say someone's come off over a few weeks because they've said, look, I want to get off these damn drugs. They have developed severe symptoms, and then you're advising them to reinstate. What sort of things can happen?
Yeah. So in some instances, people, magically get full relief and quickly from symptoms, especially it appears kind of the sooner after the 2 rapid tapers completed or cold turkey, but not always. Some people, try within a reasonably short period of time to go back on, and they either get partial relief from the reinstatement, which I see quite a bit. Well, almost everything went away, but I still have severe tinnitus and hyperacusis and this like pain in my head. They'll list a handful of things that didn't get better. And then the worst case scenario is you get no relief, or very minimal relief. And sometimes that's only initially, like if the people will maintain the reinstatement, maybe months later, the nervous system kind of figures it out and settles down. But it's hard to get somebody in that predicament to stay on if they're like, well, no, I'm back on, it's not working, so I may as well be off, And so then they start doing this like yo-yo thing with the brain, which is like the worst thing you can do, on and off, and just desperately trying to find something that helps. So yeah, I mean, I see all three: full, partial, and sometimes little or no relief. But the little or no, and sometimes the partial too, can turn into more relief just with maintained, kind of leaving the nervous system alone at the reinstated dose for a while.
Right. And
Yeah.
then you see, sometimes you hear people who, on reinstating their drug, can feel worse. Do you ever see that?
Yeah, I think anecdotally, in my experience, I've seen it more with antidepressants than I have with benzos. The benzos tend to work better on
Right.
reinstatement, or at least not cause like the paradoxical responses as frequently as the antidepressants do. Maybe that's because they're sedatives, I don't know, but it seems like that is anecdote from what I've seen. But still, we, with both, kind of start, like, do a small test dose and kind of start low and slowly increase just to make sure that the person is tolerating. And sometimes they get worse initially, and then it settles down and they kind of stabilize into it. So it's tricky. I mean, that kind of is back to the argument of, like, don't get people in this situation so that you don't have to navigate this, like, well, is it going to work? Maybe if we sit here for another month, maybe it'll kick in, maybe you'll get relief. Like, if you just do it right from the beginning and you don't take these risks, you don't have to navigate this very sticky situation later.
Yeah. So I think you're making a few very worthwhile points. So I actually, I didn't realize that it happens more with antidepressants than benzodiazepines. That's interesting to hear you say that, because I've seen it with antidepressants, and it's sort of scary. Someone's already in a lot of trouble, and then you suggest reinstatement, they're someone in more trouble. It's sweaty palms time. And you're right. I have seen some people that have held on and they've got through it and it's got better, but it's very hard to know what to say because there's so little research. Should you hold on? Should you get off it?
Yeah. Should you take more? Should you go above what you were on when you cold turkeyed? Or, like, maybe you need a higher dose now to put the flame out. Like, it's all just this, we could try it, we could try this or that. Yeah.
But you're really wandering in the dark. I guess, and the other point you made is just start with a small dose, which is what we try to do, just to get a test of things, because you're basically given 4 possibilities. Could get a lot better, could get a bit better, could have no difference, or could get worse. If I was sort of spinning that wheel, I wouldn't like to get a whole lot worse. And that's why we tend to recommend small doses to see how things go and use that to make the next decision. And also, you're right in that, it's a horrible place to be in. You're sort of thinking, I'm stumbling through a dark forest. I don't know where the traps are. And the best thing to do is to avoid being in that dark forest to start with by coming off slowly. But of course, we get people coming to us who are already in that state. And so it's out of our hands, and we're trying to navigate through, and it is very tricky to see.
I will say, I don't want people to think that I've never seen paradoxical reactions to benzos. I have. It's just rarer, I think. Yeah.
Yeah. And I guess also, people sort of think there's this definite emergency brake, that if you go too quickly, you can definitely just go back up on your drug and reinstate and everything will be hunky-dory. And I guess I've said that that's not, it's not necessarily hunky-dory. In part, this comes back to, if you're doing some sort of damage or an injury to the brain by coming off too quickly, where you can't just sort of put the toothpaste back in the tube, that's what makes me more cautious about coming off more quickly, even if it's making people go slower than they might need to.
Yeah. And, at the beginning of the call, I am a reinstatement case. I went back on and still here I am, It allowed me to not die. I was made comfortable enough to barely hang on, essentially. So I do credit reinstating with kind of saving my life, but it didn't fix the injury,
Yeah, that's a fair point. All right. And for the last few minutes, it's already been very useful. My question is the most important. What are the most common misconceptions that a clinician has about, let's say, antidepressant withdrawal specifically?
I hear that it's short-lived. Even recently, serving on the patient panel of the American Society of Addiction Medicine, making the benzo deprescribing guidelines, I had to argue with them because they put a statement in there: antidepressant withdrawal is more mild, shorter lived, and antidepressants are safer than benzodiazepines, even though I completely disagree with that statement and think there's no evidence for it. You know, that it's mostly mild. I heard a psychiatrist on Twitter the other day say comparing it to heroin is crazy. Maybe it's annoying, she said. Well, it's more than annoying in people who have it severely, all the way to it doesn't exist. I've never heard of that before. I've never seen that in my practice, which maybe they really have. I mean, I believe that that's how they feel, but maybe they've seen it and they've misdiagnosed it as all the things that we've talked about earlier in this conversation. It's just relapse, even though the patients are telling you, I never felt this way before, and that you can skip doses or that you can just taper using available manufacturer doses. Like, I think all of those things.
Just half tablets, quarter them, you're off 4 weeks.
Yeah, then take it every 2 days, every 3 days, just keep spreading it out. And yeah, I had a pharmacist tell me that today on the phone. Well, can't they just skip, So.
Yeah, and symptoms can't last too long, and you're on a small dose, so you can just stop it.
The drug's out of your system by now. Yeah, I heard that one a lot. This isn't. I mean, that drug's long gone. They would say,
Yeah, how could it be happening? Yeah. You got the same bingo card as me. So what do people in withdrawal most often wish that they had known before starting the process of tapering off their medication?
Well, most of them tell me if I would have known the drugs were capable of this, I would have never taken them in the first place. Like, what I had was not anything compared to what this feels like. So we've made them massively worse than even their most horrible reason for taking the meds in the first place. I think they don't understand sort of the difference between addiction and physical dependence sometimes. Like, people will say antidepressants aren't addictive, but if someone had explained physical dependence to them, they would have known, I wish someone had told me that your body changes in the presence of the drug, and that's totally different, than addiction. A lot of them regret not knowing how to taper properly. They all say, like, oh my God, why did I do that? Why didn't I read or learn or buy the Maudsley book or, go to Survive? How come I didn't know how to come off properly? They don't know that it could be protracted. And I think a lot of them kind of wish they knew all of the tips and tricks for tapering that exist, because they were just using manufacturer if they did taper, thinking, oh, you just, it comes down by this many increments and then you're done. Yeah.
I guess all those things sort of come down to they wish they'd gone slower. I mean, that when you say that rather than making bigger jumps with the tablets, that they'd found a way to make smaller reductions over a longer period of time. That's the general.
Yeah. And a lot of them too who start to take adjunct meds or something, like, why did I, that makes them worse. Why did I take that pill when the first one ruined me? It's just a lot of regret and hindsight, which we know doesn't solve a lot when you're already in the mess,
Yes, that's a good point. Though. Exactly. People get into trouble, clinicians will pop up everywhere and say, well, why don't you try beta blocker or a benzodiazepine if they're coming off an antidepressant, an antihistamine, an atypical antipsychotic. And, sometimes those drugs help people, sometimes they make it worse, but it means they've ended up on more and more drugs, trying to get off one drug.
Yeah. And often they're ones that have their own withdrawal syndrome. So you've just created the same problem again with something else. Yeah.
Yeah, exactly. And they all have reasonably similar issues, and exactly you've taken one drug and turned it into 4 or 5. And people that I see like that always wish they had gone back a bit on the one drug, so at least they had one drug issue rather than having 4 drug issues.
Yes. And I'm sure you see it too, Mark, but for some reason, once the person's, injured, if we're using that word, sometimes they don't tolerate things the same. Like, they're like, I took that, 5 years ago and I tolerated it fine. But in that state of neurological injury, they're reacting adversely to everything that they try.
Yeah, exactly. I see the same. Why it makes me think about, use the word injury to the brain, because they took a benzo a few years ago, it made them feel relaxed and calm. Now they take a benzo, it makes them feel agitated, all over the place. And so you think something must have changed in their brain to respond that way. I always think, if I do this to my arm and it's fine, it doesn't feel bad at all. If I have a big wound on my arm and I do that to it, it can hurt like hell. And I often think something must be happening similar to the nervous system in this state.
Yeah.
Maybe last question, as I'm flogging you for your wisdom here, is what challenges do people in withdrawal face in terms of daily functioning in work, in social life, and what clinicians do to mitigate these challenges? I'm not sure there's so much to do, but maybe talk about what challenges people have.
Yeah. So I think, again, withdrawal / injury severity kind of exists on a spectrum. So you have to see where people are. And usually I gauge it by level of function. What is this person capable of doing in their withdrawal? Some people can still maintain work, but they are struggling to do so. And they're doing it because they obviously have bills to pay and they don't want their whole life to fall apart, but they'll cry to me and say, I don't know how I'm going to this job. I go in the bathroom at lunch and I cry and I'm like crawling out of my skin, talking to my boss, And then there's people on the severe end of the spectrum who cannot work at all. There is zero way I could have had employment for over a decade for how severe my withdrawal symptoms were. And so some people are just fully and completely disabled and need support from their clinicians to get on disability, to be able to eat and have health insurance, if they can't work and they're that sick. Socially, when you're in that state, like you're not wanting to be around friends and other people. Again, if people are more severe, they are just barely hanging on, screaming, crying. It's not pretty. And so most of them are isolated. And from their clinicians, they just need like validation. They need their friend and family circle educated by someone that they're going to believe, which is you in your white coat, over the internet, basically saying, this is real, this can happen, your loved one has been severely injured, they will get better in time, but for now, these are the ways that you can help them, with maybe they need financial support, maybe they need practical support, you may have to go to the grocery store for them, you may have to drive them to their doctor's appointments, etc.
Yep, just recognition, believing them rather than saying you're totally crazily mentally ill. I remember seeing, when I think you saw the same woman who was like a management consultant or an engineer or something, very high functioning, came off metazapine, I think it was, and was basically sitting in her cupboard in the dark because light hurt her eyes so much, trying to hold it together.
Yeah.
Which I've seen a few times. I've seen sort of CEOs of companies, high-flying lawyers, people working in tech turn into basically gibbering messes, just trying to not, panic and not kill themselves, trying to barely hold it together. And they look like crazy people. If I didn't know about the iatrogenic harm from these drugs, I would have thought this is a crazy person. Then you sort of hear, actually 3 months ago, they were running this large company or they were working for IBM, and you think, So, yes, I think this is sort of a missing piece.
Yeah, and sometimes you can see it. They sometimes on camera look disheveled. I had like dreadlocks forming in my hair from being in bed, just like rubbing my head on the pillow for months and months. I had bed sores at one time. So yeah, people can be incredibly debilitated from this. Yeah.
Well, it's. I know you're not out of the woods, but you're a highly productive.
So much better. I went to the dentist today. For 7 or 8 years, I could not go to the dentist. That's how messed up I was,
Right. Because of the sensations or the driving.
I was also just in terror, severe anxiety and agoraphobia, and then to add to it some anxiety inducing thing of somebody with a drill and, all this sound sensitivity. I could barely stand to hear a bird chirp outside my window. How am I going to have some it was just not possible. Yeah.
Well, I hope you continue to improve and other people avoid going through what you've gone through, what I've gone through.
Agree. Yeah.
All right. Thank you for talking to me, Nicole. I appreciate it a lot. You've shared a lot of wisdom there.
Yeah. Thanks for having me.
Okay. How do I'm going to work out, I think, do I press stop recording? Stop recording.